My name's Alexandra, and my project pertains to patient and family satisfaction with a congenital diaphragmatic hernia long-term follow-up clinic. My supervisors are Dr. Pulicanla and Dr. Ponero. And my master's thesis topic is really centered around congenital diaphragmatic hernia and the satisfaction with the long-term follow-up clinic here at the Montreal Children's Hospital. So just a quick outline of what we will discuss today. I'll begin with some background information regarding CDH and the importance of this topic. And then next we will discuss my research questions and hypothesis for this study. We'll move on to discuss the objectives of this research and briefly touch upon the proposed methods. We'll then go on to discuss the proposed timeline for this research and where we're at in terms of the process at this time, and end with a discussion of future research directions. Perfect. So for those of you who are not familiar with CDH, it's a rare developmental anomaly where the muscular separation between the thorax or the chest cavity and the abdominal cavities fails to form normally during fetal development. This occurs in approximately 1 in every 4,000 live births, and it can occur anteriorly, which is known as a Morgagni defect, or posterolaterally, which is known as a Botchdalek hernia. This is represented by the image on the slide. The Botchdalek hernia is more common, and CDH occurs more commonly on the left side of the diaphragm, occurring approximately 80% of the time. So when this failure of diaphragm formation occurs, the abdominal contents are free to herniate or move into the thoracic cavity, resulting in compression of key thoracic structures such as the heart and lungs during fetal development. Lung compression results in pulmonary hypoplasia, or poor formation of the lungs, and pulmonary hypertension, which is increased blood pressure within the vessels of the lungs. Anomalies which are the leading cause of morbidity and mortality in CDH infants. The diagram on the right represents a left-sided CDH, which is the more common type, where the infant's stomach, intestines, and part of the liver have herniated into the chest cavity. As you can see from this image, this actually compresses the left lung so that it's much tinier than the right side, resulting in poor lung development or hypoplasia. And this would be the most common finding that you would see in CDH infants. So in addition to the major effects seen on the pulmonary system, CDH infants suffer multi-system morbidity that affects their neurodevelopment, their nutrition and growth, as well as the cardiac, gastrointestinal, and musculoskeletal systems. And these impairments can have long-lasting impacts throughout childhood and into adulthood. And the impact of these morbidities does not only affect the child, but can also affect the family or caregivers in a manner that is similar to other chronic diseases such as cystic fibrosis. The good news is that CDH survival has improved greatly to over 80%, and this is largely due to advances that have been seen in intensive care, surgical techniques, as well as increased and more effective utilization of ECLS or ECMO. Given the improvement in mortality statistics, research has now shifted from improving mortality to actually improving survivor morbidity. And when we consider survivor morbidity, neurodevelopmental impairment has been found to have the greatest impact, as up to 2/3 of CDH infants experience some form of neurodevelopmental or psychomotor delay by age 3. What we know is that structured long-term surveillance is critical for the early identification and mitigation of these morbidities, especially for those patients with neurodevelopmental impairment. So given the importance of identifying these morbidities early, multidisciplinary structured surveillance programs composed of pediatric surgeons, pediatric subspecialists, such as respirologists or cardiologists, as well as other healthcare professionals, have become an essential component of clinical practice guidelines. But despite recognizing the importance of these long-term surveillance programs, very few studies to date have actually examined the impact of survivor morbidity on patients and families. Nor has there really been a critical evaluation of the types of resources that are actually available to families and how these can be accessed by families. Furthermore, research has failed to address the efficacy of these long-term follow-up clinics in mitigating morbidity and supporting families effectively, nor have we actually looked at if families are satisfied with these clinics and services that are provided. So it's this lack of information that prevents the development of quality improvement initiatives related to community support for these patients and for these families. And then just a few words regarding our local context. So the long-term follow-up clinic here at the Montreal Children's Hospital was established in 2012. And within our patient cohort, we have approximately 25% of our patients that have been identified to have some form of neurodevelopmental impairment, with most of those patients belonging within the moderate to severe category. And this was based on neurodevelopmental assessments, which were performed at 18 and 36 months of age. So this leads us to the research questions which will govern this research, and they are as follows. What is the clinical care trajectory of CDH patients with neurodevelopmental impairment, or NDI? Are there specific periods during which the frequency of surveillance or the level of support should be increased? Are these patients and families satisfied with the medical and community support that they receive? And do they feel that the support offered or available to them meets their needs? Now, our hypothesis is that children with CDH and moderate to severe neurodevelopmental impairment will have lower health-related quality of life and less satisfaction with existing CDH support resources, both at the Montreal Children's Hospital and within the broader Quebec community, compared with those patients who do not have neurodevelopmental impairment. And in order to assess this, we have some objectives. So the overarching goal of this research is to describe the evolution of disease for patients with CDH and neurodevelopmental impairment, and to evaluate the impact of this condition on their quality of life. In order to address this goal, we'll explore the following objectives. So first, to describe the clinical trajectory of patients with CDH and moderate and severe NDI using the established CDH long-term surveillance database, neurodevelopmental screening information provided by pediatricians, as well as disease severity stratification based on the validated CDH study group score. Additionally, we'll be hoping to identify existing community support resources for families with CDH and NDI and approaches to improve them. And lastly, we'll be evaluating patient and family satisfaction with the CDH long-term follow-up clinic here at the Montreal Children's, as well as existing resources both at the Children's and within the wider Quebec community. So in order to accomplish these objectives, the study is going to follow a sequential explanatory mixed methods study design. And that's going to be performed in 3 phases. These 3 phases are a retrospective chart review, patient and family satisfaction surveys, and then focus group with patients and families. And I'll describe each of these phases in further detail. So phase 1, which is our retrospective chart review, will involve chart review and data analysis of the existing REDCap database, as well as patients' charts. 27 patients within our long-term follow-up clinic have been identified to have CDH and moderate to severe NDI and will be included in this phase of the research. The inclusion and exclusion criteria for the study are noted on the screen. And just something important to note is that we'll be looking at patients that only have moderate and severe NDI. Those with mild NDI or without neurodevelopmental impairment will not be included. Additionally, we will only be including those patients with botched hernias and those diagnosed prior to 28 days of life. So phase 2 follows the same inclusion and exclusion criteria as phase 1, meaning that once again, 27 patient families are eligible to participate. And this will be a survey that will be sent out to these participants. We are using a survey that was designed after the esophageal atresia clinic satisfaction survey that was used here at McGill. It'll be available to these families both on Google Forms in French and English, as well as in paper copies. And then lastly, phase 3 will involve 3 to 5 focus groups of 4 to 6 participants each. The goal of this phase of the research is really to gain a better understanding of patient and family resources as it pertains to CDH and NDI. And the results from the data obtained in phases 1 and 2 will be used to help form the question guide for the focus groups used in this phase. The first focus group that will be held will be used as a pilot to help find the question guide where we'll ask participants to comment on the questions, their relevancy, any missing questions that we should be asking. And this helps to ensure that the questions asked are relevant and meaningful to the participants and also serves to engage patient partners. In terms of some of the topics that we plan to explore in this phase, we'll be looking at a description of the support resources that are utilized in the community by families. Additionally, we'll be further delving into patient and family satisfaction with the existing resources at the hospital and within the wider Quebec community or Montreal community. And then lastly, we'll be looking at participant identified gaps within these existing support resources and what needs to be improved. In terms of feasibility for this project, we've already received REB approval for phases 1 and 2, with plans to submit an amendment prior to beginning phase 3. And we'll be doing that so that we can actually submit our question guide for that phase. All of the data for phase 1 is already collected within our REDCap database and patient charts, and we don't anticipate any recruitment challenges for phases 2 and 3. So in terms of where we're at with this research at this point in time, data collection for phase 1 began this month, and I'm hoping to have that finished by the end of February or beginning of March, with data analysis to follow. In parallel, we have data collection for phase 2, which we hope to begin next week, with analysis to follow that as well. And then lastly, we hope to have preliminary results from phases 1 and 2 to guide the resubmission of the REB for phase 3 towards the end of March, with hopes to begin participant recruitment in April. And hopefully this isn't too much of a lofty goal, but ideally we would like to complete those focus groups before the summer months. As we know, many patients and families are away at that time. So just to sort of finish here, I'd like to end with a brief discussion of some of the future directions for CDH research at the Children's Hospital at this time. So one of the things that we're working on is completing a baseline assessment of quality of life for these patients. And that's using previously collected psychosocial and quality of life data that Dr. Altit has collected. The results of this analysis will actually help to inform some of the questions that are used in phase 3 of our research. So I think that will be very meaningful. Additionally, we're currently evaluating the impact of standardized care. And what I mean by that is that we are assessing the impact of the Canadian Clinical Practice Guidelines for CDH on patient outcomes. At the moment, we've just received REB approval here at McGill to begin that study, and we hope to add additional large Canadian sites to assess the Canada-wide impact of these guidelines on care. So that should hopefully be underway throughout the new year as well. And then lastly, we're looking at long-term follow-up. As part of that, I've already mentioned where phase 2 of our study will fit into looking at satisfaction with long-term follow-up. But we are also completing an overhaul of our REDCap database, or our data collection database that we have here at McGill, in order to be able to improve data sharing capabilities, not only within Canada, but across North America. And I think the value with that is that by being able to share our experience and our data with other larger hospital sites within Canada and in North America, we'll be able to see what the trends are and perhaps where there needs to be greater focus with interventions that could be helping these patients. And that's the overview of my research. I'll welcome any questions or comments.